All right. Welcome, everyone. It looks like we have a good number of participants today, and I'm excited to be able to talk with you all for the next 45 minutes or so about navigating resistance in the therapeutic relationship. This topic is something that I think a lot of us struggle with. And it can make us often feel like we're not doing enough or that we've done something wrong. It can really lead to a lot of disconnect with our clients. And a lot of us have a very strong desire to not have this happen. So my hope is that we can talk today a little bit about some tips and strategies for how to address this. My name is Cynthia Grant. I am the head of clinical care at PATH. I'm on the executive leadership team, and I know we have many PATH therapists who are joining us today, which is great, so welcome. I am a licensed clinical social worker. I also have my PhD in social work. I worked as a social work professor for about 10 years, but most of my experience has been in hospitals, community mental health, and in particular in private practice. I have had a private practice in some capacity since 2003, which I know dates me a lot. And in particular have been doing telehealth since about 2013, 2014. I am located in the Denver area. What you see behind me is my backyard. You can't see the snow, but it's there. And I am joined today. Jen is my colleague who is working a little bit in the background. She'll be managing the chat, and we'll pop back on when we're ready for some Q&A. So this topic that we're going to be talking about was actually submitted by some of our prior webinar participants. We know that a lot of people are going to experience this. This is a very normal part of the work that we do. And so I was really pleased to have this come up as a topic. What I'm going to do, I'm going to share my screen and get going on the slideshow portion. Jen will probably let me know if for some reason something doesn't work, but I'm assuming that we are all together. So my goal of this webinar is largely to be able to leave with some increased insights about navigating resistance in the treatment relationship, and then in particular to have some very tangible strategies. I never like attending a webinar if I'm not going to get something concrete to take away. And so just know that that is part of how this webinar is structured. We are going to talk a little bit about how resistance shows up in the treatment relationship. The term itself, resistance, is actually controversial. And so what I'm going to do is I'm going to go over a little bit about that. There's actually all different types of resistance, and some of these can be pretty uncomfortable. You will never hear me use the word non-compliant with treatment, but even resistance is something that sort of implies a little bit of a power differential, or that there might be a right or a wrong way of doing something. So I want to be mindful of that. I am going to switch gears to talk about rethinking resistance in the context of the clinical relationship and what that actually means. We're going to talk about a concept called the mouse in the room, which I think is a good one to think about with resistance. And we'll talk about this both from the lens of things that we as the therapist should be thinking of, as well as things really of how to approach this with a client. I will leave some time for Q&A. Please use the chat to put your questions in there. Generally, I cannot see the chat while I'm presenting, but Jen is there keeping track of it. So let's talk first about how resistance shows up. Most of you are familiar with these concepts. We see sometimes that there's arguing or conflict, a tension that arises in the interaction with our clients. Sometimes that manifests with interrupting. You might also see that someone is denying that something isn't true. That might show up as blaming other people, saying things like, "You don't understand," making excuses, or just being unwilling to change. Other ways that you may see this show up is when people are ignoring what the other one is saying. where someone might disregard a suggestion or even just flat out not answer a question. In some cases, resistance will manifest with behaviors such as missing or canceling appointments. And there might be an added excuse in there about, oh, well, something has come up. But here's the catch. Resistance is a two-way street. If you feel like your client is resisting you, you are also likely resisting the client. And I want folks to pause and think about that just for a minute, because all of these lists, initially, when I was putting these together, you think, oh, this is what the client does. But in reality, sometimes this is what the therapist does. It's a really important point to outline that when we're talking about resistance, it could be the therapist's behavior that is actually causing some resistance or those reactions in the session. There's a common quote that many of us use that you can't change other people, you can only change yourself. And we tell our clients that. I've heard it a lot. But then we go into a session and we often are trying to change our client. And so that dynamic is a little bit hypocritical, and it can actually promote some resistance. So I will be talking about how we are resistant to clients in treatment, but I don't want to put people off too early in the talk. It is a common reaction for when a resistance emerges for us to blame the client. And I just want folks to be aware of how we may also be contributing to some of that tension that exists. In preparing for this presentation, I was doing some research. I know a lot about resistance from my clinical experience and having done some reading on it. But then I came up with, there was one article that actually had 25 different types of resistance. I wanted to distill it down to just a few that I think are helpful for us to be able to name it, because resistance is not one size fits all. Realistic resistance happens when a client is very conscious or has a deliberate opposition to something that gets recommended in the therapeutic relationship. We do see that resistance might be to a particular approach. There may be resistance to a therapist, gender, ethnicity, age, training, telehealth modality versus in-person. There's a lot of realistic ways that a client might be very conscious of why they're resisting to techniques, the therapist, something in particular. So that would be considered, to a certain extent, a healthy form of resistance, in that it is something that you can address, but it's also something that likely exists that has nothing to do with the actual interaction between the two people. Collusive resistance, on the other hand, is a really interesting concept. What this means is when we as a therapist might avoid painful topics due to different countertransference reactions that we have. So what may happen is that we may agree with the client that they shouldn't do something, or we may agree that someone else is to blame. And while there's definitely a time for validating every client's experience, I think it's also really important for us to keep in mind that there is another type of resistance that can emerge, that can interfere with the treatment relationship if you are too closely aligned with the blame and resistance to change that the client might be experiencing. Another category on here is outcome resistance. And this occurs when the client doesn't really want to be able to have a good treatment outcome, whether it's conscious or unconscious. These are situations when a client really may not want to change. I think of people who have dysthymia, who being a depressed person is part of their persona, and that is maybe how they get attention from other people, and they may not be ready to be able to give that up. We certainly see people with alcohol misuse disorders that they may be resistant to being able to give up who they are as someone who has fun and drinks and doesn't view it as a problem. And so that outcome being, to a certain extent, just not wanting to change is one type of resistance. The other one, though, process resistance, I think I have seen more frequently, in that regardless of how a client may feel about the treatment outcome, they don't want to do what is required in order to be able to make that happen. And so these can be very hard conversations. It can be difficult to be able to work with a client who truly does not want to do the things that it takes. I think of weight loss as certainly falling into this category. But I also have clinical situations where this has happened with a wife who did not want to leave her husband because she was the steps it would take and were not ones that she was willing to do. We've seen people who will stay in a job and they're not willing, ready to be able to make a change because of whatever different motivators they have. Process and outcome resistance often go together, but they are a little bit nuanced. So I just wanted to call that out. The last one on here is really where I want to switch gears, and that's to conceptualize the concept of resistance more as ambivalence. And ambivalence is something that many of us can reconcile with, that it's very common to have ambivalence about any sort of change. In particular, ambivalence is one of the keys to actually being able to make a change. So the very thing that brings a client to therapy is often the thing that they are most afraid to change. So we might personalize resistance that a client experiences, such as, and we might see this happen, that we think they're vying for power, or they're trying to frustrate us, or they're just rejecting us. And these feelings can lead us to have a lot of different reactions. We may get frustrated. We might even reject the patient and say, no, this client isn't a good fit for us. But I just want to mention that if someone didn't have ambivalence about the need to change, they wouldn't be in therapy. They would be able to handle it on their own. The other piece that is just foundational associated with any sort of change is that resistance to change is normal. And the fear of what is unknown is also very normal. It can cause a lot of pain based on the client's experiences that they've had in their life. You can really start to see some of the things that a client might be afraid of or hurt by, or remorseful if they have to make a change. I have a client that I might refer to in this talk. I have a client who is really struggling with a partner who has a substance misuse problem. There just recently was some new interpersonal violence that occurred in the relationship. She has young children. She is the primary breadwinner, and she has consulted an attorney and has learned that if she divorces her partner, that she will be required to pay alimony to him. It's obviously going to be disruptive to the children. She has some fears about how the child's father will go downhill. Every point that she is experiencing in regard to both the process and the outcome resistance that she may be experiencing is highlighting things she's scared of, things that she feels pain, things that she feels like she hasn't been able to save or fix her husband. And so it's just really, I feel like ambivalence is such a great way for us to be able to tap into the life that we see of how our clients are experiencing things. Other times we see ambivalence that shows up as an interpersonal deficit, and we might see that an individual is really someone who is typically confrontational. They may struggle with that one-up position that I feel like we all know someone where when you're having a conversation, you can barely get a word in because they're already thinking of and planning what they're going to say. That's often comes out in interrupting. it may be their excuse, their reasoning, a rebuttal. And that happens in real life, but it also plays out in therapy, that parallel process. And so being able to be aware that sometimes that ambivalence is something that needs to be worked on itself in terms of how an individual is coping in the interpersonal space when they are not in agreement or somewhat resistant to change. We also see this come up from a developmental perspective, possibly neurocognitive, but children, young adults, that can even extend into adulthood, but there are definitely times when I feel like that teens and young adults, even children in session, you're going to see resistance play out in a little bit of a different way, but it may especially be because developmentally, that's the way that they know how to interact. One thing that's worth calling out is that sometimes we also have ambivalence to change because the therapist, we want the client to change more than the client wants to change themselves. You do see situations when there may be resistance that emerges because a therapist is trying too hard to be able to help a client. We see this sometimes with new grads. We sometimes see this with a new clinical situation that you've never dealt with before. Again, those countertransference issues that I mentioned before, there could be sort of all different reasons why something like that could come up, but it is a very real reality that sometimes we want a client to change more than they want to change themselves. So given that we all know a lot, and we're learning about resistance, ambivalence, all the different reasons that we know that resistance to change is normal, why is it that we are still resisting our clients? I think that this is an important point for us really to dig into a little bit. Resisting our clients' resistance does slow down the therapeutic process. When we resist our clients, they often pull back even more forcefully, and it becomes like a little bit of a tug of war between you and the client. At its core, this is really about the therapist-client relationship and how we're interacting with a client. Sometimes we simply don't know what to do. I have sat with many clients who present a life situation that is so complex, or they have a trauma history that's so painful. There's really no words for it. I'm not going to say anything magical that's going to take away their pain. I can't necessarily come up with a list of action steps to be able to make them feel better. Sometimes clients, especially if they've never been in therapy before, they come to us thinking that we're just going to tell them what to do or how to make things better. And then they get frustrated when we don't have the answer, whereas most of us know that's not how therapy works. But for many clients, they don't know that. And so the technique that I may need to use in these situations where we just don't have the answer or we're sitting with someone's pain, we may just be using active listening and reflection without going into any sort of problem-solving mode. The other item that I have on here, the lack of understanding of why the client is responding the way they are. To me, this is about the importance of understanding the client's world. It's very important to be able to know what the client's perception of the problem is, not what our perception is, but what their feeling is the issue that's bringing them in. What's the client's goal for treatment? It shouldn't be my goal or something that the client might even not even be aware of, but that I've conceptualized myself. This should be a mutual goal that gets discussed, that the client agrees to, that yes, that's what we want to work on. This is really the key to a strong therapeutic alliance, is that we are working on those mutually identified goals and that the client is in agreement with that. Are we working on the wrong problem, or are we working on a problem that the client doesn't want to work on? If so, we really need to be able to switch gears. At PATH, we emphasize the use of Therapeutic Alliance questions during every visit. It's a great way to be able to check in, to be able to see if the client feels like that the therapist understands what's actually happening and if there is agreement still on what it is that's being worked on. So I really view that as a strong connection. The third point that I have on here is something that I feel like that we've all had clients who come to us, especially at the beginning, where they tell us they don't know. They don't know what they want to change. They don't know why they're in therapy. I just had a really nice dialogue with a therapist not too long ago who was struggling with this. What do I do? It's the third session. They still say they don't know why they're there or what it is that they want to change. They just know that they're still experiencing anxiety or depression. How we handle these particular situations in the relationships are really important. I don't view when someone says, I don't know of why they are there or what they want to change. I don't view that as a barrier. I really view that as a doorway into the struggle that they're having. I want a client to be able to sit in silence and really think and experience emotions without having to have a quick answer. Making what's unknown an opportunity to be able to build rapport with your client and to be able to figure out what the goals are is really a gem that I feel like we need to tap into. We can keep a curious position and be able to stay puzzled and unknowing. We do not have to have the answers for them. And that by nature should be something that allows us to get them talking. And so I always encourage clients to analyze their situation and explain why that particular situation is important to them. What is it that they're talking about? So here are some very specific tips that are out there for being able to manage resistance. The first one here is the one that I think most of us are the most familiar with, and we have to keep ourselves in check to really stay out of the expert position when there is resistance in the relationship. There definitely is a time when a client is looking to you as an expert on a condition, on symptoms, on coping strategies, homework, things like that. I'm not negating that. But the more resistant the client, the less knowledge we should claim to have, especially about their problem, their situation, their ambivalence. The more motivated the client, the more knowledge you can share. But you really have to be mindful of not getting into that expert position when there is resistance. Another tip that's worth considering here is do not push the client until they're ready. That can lead to more resistance, and it's always best to take very small steps as we pull out details and then give the client time to process. The idea of taking small steps, of not going into overly questioning mode, is something that allows us to really focus on the dialogue. When we start to ask too many questions, dig for detail over and over and over again, that can actually be a type of micro confrontation that we're initiating without even realizing it. And so this point here is don't argue, don't inadvertently get into an argument with the client, even when you might not be realizing this. And when I was prepping for this webinar, I thought the best example of this comes out in the parent-child relationship, right? It's how many questions we ask, how deep do we go, how do we allow there to be a dialogue and a conversation versus us just sort of simmering and getting under the skin of the person that we're asking those questions to. So ultimately, that is about don't, as a therapist, create those arguments. But it is something that plays out. And the last item here, and these tips, I guess I should say, these are specific to things that the therapist can do. But the last point here is really to treat that resistance with respect. there is a lot of value in being able to understand and name the type of resistance, especially if we are bringing it to the table. Is it when we're thinking about how our clients are reacting to us, we deserve to give that space to determine, is this outcome resistance? Is it realistic resistance? Is there some sort of collusive resistance that is happening? So really being able to pay attention to that. I do think that it's very important for us to be able to dig in and to understand why the client is ambivalent to change. We could spend 1 or 2 sessions just exploring with that particular area. I put on the slide about seeking emotional reasons for change, rather than leaving the husband, getting a new job, improving my health. I also want to think about what's the true meaning? What will this mean to you in your life? There's often a miracle question that gets thrown in there in terms of, what would it be like if your life didn't have X, Y, and Z? With the resistance, though, I also want to emphasize that as a therapist, we should be paying attention to our triggers and what our triggers may be for wanting the client to change, especially if it's something that they're not quite ready to change. And then the last point about treating this resistance with respect from the therapist's perspective is really to pay attention to why you may be resistant to the client. That's a great topic to bring up if you have a supervisor, and certainly if you have peer-to-peer clinical case consultation where you can talk with someone to really be vulnerable and to explain, this is what I'm feeling when I'm in the room with the client, and to be able to get another perspective there. So as we start to make that transition, I want to get us to rethink resistance in a way that frames it so that we can truly use resistance in a way that is helpful to the client and that doesn't burn us out or make us feel like we're being inadequate. There's a common metaphor in this space about identifying the mouse in the room. And I think that this is an interesting concept here, because this is when something may go unnoticed by the therapist. And so a client, especially who internalizes a lot of their emotions, they're not likely to say anything if they disagree with the therapist or if they aren't able to articulate. And sometimes you see therapists that are clients who are even just going to go along with whatever suggestion the therapist has, but then they might not take that next step of what it is that they need to do, and we wonder why. The client who may avoid certain topics or not bring something up that may have been alluded to initially, this is where it is important for us to be able to call that out. And the mouse in the room is disruptive. It's disruptive to the therapeutic process. It's disruptive to your relationship. And you see the mouse too. So they know the mouse is scurrying around, and it's important for you to stop and also call that out. So this concept of identifying the mouse in the room really allows us to reframe how we can use resistance or treatment ambivalence in the process of the therapeutic journey. I also think that there are always going to be times when there's resistance or a lack of fit between a therapist and a client, especially at the beginning. And I view this as an opportunity. There is an opportunity to repair a ruptured relationship that emerged, especially if the clinician was resistant or wanting the client to change when they weren't ready. Ruptures often stem from instances when we may actively engage in a technique that just doesn't resonate with the client, as well as sometimes the therapist doesn't do what the client thinks that we should be doing. So this is an opportunity really to be able to practice skills that are needed for interpersonal conflict resolution. And you can model that with a client in a way that can ultimately make your relationship stronger, because they'll feel seen and heard. And they'll know that you're not avoiding a topic that oftentimes other people in their lives are avoiding. The other thing that is relevant in terms of being able to rethink what's happening here is really that sometimes it's important to stop and identify good reasons why the client would not want to change. There is a lot of value in being able to talk about the reasons why someone does not want to change. And the client may actually appreciate that you are, again, understanding, hearing that, and not pushing for change when they're not ready. The situation I mentioned earlier about my client who is in a difficult situation with her husband and has young children, she is not ready to make a change. She's not ready to leave her partner. She's not ready to have her children go through this disruption. And she doesn't feel like that now is the time to talk about it. So we don't spend time in session talking about what she could do, should do, or what life would look like if she wasn't there. We have taken a very different approach because that is something that she's not ready to change. And so we've worked through that. We talk a lot about not shaming or blaming when there's situations that emerge, the pain that comes out, even when you make a decision not to change, but that can still be difficult. But that is something that is a different way of thinking about resistance. So I'm going to switch gears to talk a little bit about some additional tips. These are things that you can also think about for yourself, but sometimes these are things we're also modeling for our client. Staying calm and being aware of our emotions and physical reactions that we might be happening is something that I feel like that there's value in us naming that, as well as being able to teach the client how to recognize how they're physically feeling, their emotions, as well as their physical state. If you're feeling confused by a conversation, if there's dread, if you feel your heart racing when you're in conversation with someone, it's a great opportunity to really pause and be able to think even briefly about what is happening with me. And again, you do that for yourself, but then you're also teaching your client. The alternative, of course, is when you get all anxious or somebody has a reaction, if they're fighting back and arguing, that's actually only going to escalate the situation. And so being able to stay calm, especially when there's tension, resistance, or something in a conversation, is just incredibly valuable. Another one that I have on here is about the value of expressing empathy. Expressing empathy for a situation that is happening within the context of the therapist-client relationship is something that might be a little bit challenging to do for you as a therapist, but I feel like that this can really validate what the client is saying or how they're presenting in the relationship. I may say something like, "I'm really sorry that the way that I was asking you questions made you angry, or that you didn't feel like the activities or the coping strategies we talked about were going to be helpful. Can we continue to talk about other ways that we can work together?" Being able to have a very genuine and authentic way of apologizing for some of the tension that is occurring in the relationship is a great way to be able to avoid further escalation, to reset, to do some of those rupture repair. But I do feel like that there's value in that. I also think that there are boundary setting that has to take place when there is resistance that comes out in very unhealthy ways. If you have a client who is getting aggressive with you, who's swearing, who may fail to show up and have multiple missed appointments, if they refuse to pay for services because they don't like the way that you delivered care. Those types of things, we do have to set the stage and be clear that those are not acceptable. So I'm not at all suggesting that we express empathy and apologize for very negative behavior in the therapeutic relationship. But we do want to call that out, and we do want to make sure that we have clear expectations with our clients. I think that once you have shown a client that you recognize and understand them, even that they're ambivalent to change, that can really be a turning point in working through some of the topics in your relationship. As a natural part of doing that, you are cultivating patience. You have to be careful that you're not projecting your own angst or discomfort onto the client or the treatment relationship. So if you're not sure how to handle a situation, give yourself some grace, make sure that you're patient. I think that we also need to remember that modeling for the patient can be a very useful skill that you're demonstrating to them. So when a client says, I don't know, and when they say it again, and when they get frustrated because they don't have a solution to a problem that they've been trying to solve for years, I think there's great value in letting them know that you recognize that the problem is hard. It's hard to figure it out, but that you're going to work together to be able to resolve it. That's part of a very patient approach to working with a client. And then the last item that I have on here is the reality, is that there are going to be times if resistance continues, if it's very inappropriate, some of those boundary setting items I mentioned earlier, then you may want to consider terminating the relationship. It is ultimately the client's needs come first. If the client believes that you as a therapist, that you're not meeting them where they're at, or if the client is so resistant that you know that you can't be effective in working with them, that there may be a time to end the relationship and refer the client to another provider. So we all have our limits, and I think that this is something that I would be remiss without mentioning that as part of the webinar as well. So the content part we've covered, but I want to be able to switch gears and see if we might have questions in the chat that came through. I think that, again, there's so many universal issues that come up with resistance that my hope is that a lot of you joined because you know that you have experiences, will continue to. And so, Jen, if you have comments or thoughts, the questions that have come up, I'd love to be able to take those.
Yes, absolutely. Thank you so much, Cynthia. So the first question that has come through, can you give some examples of how to address the mouse in the room without being too assertive?
So I think that assertive means different things for different therapists, and it means different things to different clients. And so sometimes I feel like we just have an innate, intuitive understanding of how much we can push or assert ourselves with a client. Taking a more gentle approach of being able to say something like, you know, this has been a hard session. Have you felt it as well? Might be one way to be able to open that door. Again, very small statements to be able to open the door to let the client know that you're validating their experience is probably going to be one of the easiest ways to be able to crack the door without being too assertive. If the client resists and says, no, I didn't feel it, I think the session has been fine, then I would probably say, thank you for sharing that. That wasn't my experience, and I just wanted to check in with you to see how we were doing. Let's continue to keep an eye on it, but for now, we can move on to a different topic.
Great, thanks, Cynthia. Another question that came through. What suggestions do you have when a child is resistant to treatment, but the parent keeps insisting that their child needs therapy?
Yeah, I think that most of us have had a client, a clinical situation like this. It depends on the age of the child, but generally speaking, I do think that it's very important to have some buy-in from your client for being there. This may happen in a client-parent relationship. It may happen in a couple's relationship. But depending on the age of the child, if it's a teenager, for example, you're not going to be able to do a thorough assessment, get the questions answered that you need, or be able to move things forward. There's also a lot of risk that the child will see the therapist as aligned with the parent. And so one of the ways that we can sometimes work around that is by having clear conversations at the very beginning with our clients and with the parent to be able to explain the limits of confidentiality, what you will and what you won't share with the parent. And so being able to do what we can to create a safe space with the child client is something that I think can really set the stage right off the bat. I have had a client who sat there and wouldn't answer any questions. And so how long do you wait in those situations before you potentially rope the parent in? And in that case, I'm doing more education with the parent and potentially talking about other suggestions, because if the child client is not able to engage, then it's not going to be a helpful relationship.
Great. Thanks, Cynthia. Another question, what do you do when the client blames the therapist for a lack of progress?
Mhm. Yeah, that's a tough one. Sometimes we believe it. And so I think one of the things that's most important is for us to keep ourselves in check, to be able to really think about, is there something that we have done, or is the client using us as, to a certain extent, a scapegoat, or blaming us for the lack of process? I'm always going to put that question back to the client. Tell me why you think that way. What is it specifically that happened? I'd love to know more about that. That concerns me. I'd really like to reset. How can we talk about that? Because I certainly don't want to block your progress. So I'm throwing out a lot of different phrases and words of how I would probably respond to that. I think that any of those could potentially work. And I do know that we have had clients, and sometimes they do this, it's a doorknob confession right as they're walking out to tell you, and that can be tough. I have followed up with an email after a client has done that sort of right out the door and have said, I really hear what you say, and I'm hoping we can have time to talk about it. My goal is to be able to get them in for another session, because I think that, again, that's one of those situations that life is mimicking what's happening in the therapy space. And so it's likely that they're doing something like that in other settings where they're blaming other people. So I do think that there's some key things that we can say to be able to continue to try and work through that.
Great. Another question came through. Wondering if you could revisit the meaning of collusive resistance. I'm still trying to conceptualize what this form of resistance can look like.
Sure. And I'm by no means an expert on these different categories. So Google is your friend. But the idea here is that if a client is resistant to something, resistant to change, and you are agreeing with them, you may actually be blocking the process from being able to move forward. So if I am too aligned with my client, I could create a situation where, instead of them stepping up and taking responsibility and being able to have some insight into their situation, then I may also let them off the hook and blame another person. So if you think about adult children who have a parent and they're very upset with the parent, something that the parent has done in the childhood, oftentimes a trauma, neglect, abuse, that type of thing. If I, as the therapist, agree that their current situation and their circumstances are due to this parent, and that the focus needs to be on the parent and what happened, because the parent was the one that was wrong, I'm setting up a pretty unhealthy dynamic where I am colluding with the client in agreement with them that someone else is to blame for the way that they're handling a situation. And in almost every situation, we know that that whole concept of you can't control other people, you can only control the way that you react. If I am too closely aligned with the client around a situation, then I am going to prevent them from actually being able to figure out how to work through a situation on their own. So hopefully that example gives a little bit more context, but a lot of collusive, the idea of collusive resistance is that you can validate what's happening with a client, but you don't want to get into so much agreement about their what they're ambivalent to change about that you are actually part of the reason why they're not willing to change.
Awesome. Thanks, Cynthia. Another question. In the last slide, you explained considering terminating the relationship. How can I find the best timing and bring it to clients to avoid the oppression of abandonment?
So a lot of our training, we're told that termination starts from the very beginning of the relationship. How do we know when we've accomplished what we needed to accomplish? Or in this case, how do we know that we haven't accomplished it? I think that that concept of the mouse in the room is going to come into play here. If you have been calling out that there is tension, if you've been recognizing it, and to the question earlier about not being too aggressive, but you've been gently bringing this up, and it's still occurring, then I think that mouse is getting bigger. It's turning into a rat. And so in this case, you're probably going to want to bring up to the client that we have talked about this in the past, that it seems like that there's really some barriers to treatment. And then in this case, I may take some responsibility and to say, maybe it's because of the way that we interact. Maybe I'm not the right therapist for you. That doesn't mean that there's anything, flawed with you, but this could just be about our dynamic. And I would really begin to think about what type of, I would begin to start conversations with the client about what type of therapist, what type of approach do they feel like might be most helpful, so that I can then identify whether or not I have that approach. Now, this is an ideal situation if you have a client that's engaged and you're able to have a conversation with them. Sometimes when a client just disappears, stops showing up, you're going to have a little bit of a different dynamic. I do think, though, that if we, anytime that a client makes a choice not to return to therapy, that is not client abandonment. That is their choice. This happens a lot in all different types of situations, that a client literally just stops coming to therapy or they stop scheduling. There's no abandonment that takes place in those situations. In other situations, though, when you're trying to articulate to a client that you really don't feel like you're the best fit, it's important to phrase this as part of their treatment, that this is actually something that I believe is going to help you. And my goal, the real reason why I'm here, is to make sure that you get the help that you need, even if I'm not the one to help you. And so I would really change that dynamic of the relationship to be about that this is a way that I can help you more, and that I believe you'll be able to get better faster if you're working with someone who maybe this dynamic isn't happening.
Great, thanks, Cynthia. Slightly longer question, kind of more situation based. One kind of resistance I encountered was someone who would talk about very surface level things in session. When I would try to ask what they wanted to explore in that session, they'd say, I don't know. I got the sense that the client, who is a senior, was using the therapy to meet social needs, but was also very ambivalent about therapy and perhaps not ready. Curious what your thoughts are about this.
So whoever wrote this question, I think you already have thoughts about this, right? So age, the social dynamic of coming in with therapy, also having ambivalence, depending on generation, there's obviously different stigmas and preconceived notions about what therapy is. I have also seen this with people who have chronic and severe mental illnesses, that they're used to being engaged in therapy over a long time. I think that situations, what was the question in there? The question was, how do I conceptualize when a client says, I don't know, and it's because they're ambivalent? Is that what it was, Jen?
Yeah. So if So I got the sense that the client who is a senior is using the therapy to meet social needs, but was also very ambivalent about therapy and perhaps not ready.
Right. And so this is a topic in itself to talk about with the client. Both the social nature of therapy, friend therapy is something that many people who are very lonely and isolated often do look to that. And so a big part of our job is to try and teach them some of the social skills that they need to be able to develop friendships. And so identifying that as a treatment goal might be something to address that social aspect of treatment, that maybe you're coming to therapy in part because you view me as someone who's supportive. And my goal I'm going to check myself. Our goal might be to think about how you can develop these types of connections outside of a paid relationship with a mental health professional. So I think that that's one strategy. I always have in the back of my mind about medical necessity in terms of, does this person actually have a diagnosis? At PATH, all of our clients are covered by commercial insurance. Commercial insurance is crystal clear that if a client does not have a billable mental health diagnosis, then they should not be in treatment. It also creates blockers to access care for other people who may need it. If we have people who are ambivalent about therapy, if they're really not progressing in therapy, or in particular in this situation, if you're using it sort of as a social connection. So I do think that there may be times where that becomes the goal itself, and that there again may be a discussion of, well, whether or not the person actually needs to be in therapy. Sometimes I feel like our profession undermines ourselves, and that it's really important to remember that we are master's and doctoral level licensed professionals providing a healthcare service. We are not supporting people in their self-esteem. We are not doing self-actualization. There was a time back in the 80s and the 90s, the psychoanalytic movement, there was a time when some of that would happen, but commercial insurance doesn't do that. And so if a person is engaged in therapy and they don't truly have a diagnosis that is part of what you're working on in the therapeutic relationship, I would really open that up as a conversation. So again, maybe that first goal is to look at how to be able to develop relationships outside of the therapy relationship, but then also really considering, does this person have a diagnosis that would necessitate treatment with a licensed professional?
So Cynthia, we have a follow-up question from the person who asked this question, which is specifically kind of looking for advice around when someone's keeping it really surface level in a session and that kind of resistance, what your advice would be.
Thanks. Sorry, I know there was another part of that question too. Surface level folks, they kind of present their own challenge. And it's like, what type of resistance is that? Is it that they're not ready? Is it because they don't trust you yet? Is there not strength enough in the relationship that they're ready to tell you more? Is it because of their own internalized stigma associated with therapy? And I would really want to be able to understand that in terms of what the person's motivation is. It takes quite a bit of work to find a therapist. You have to go through your insurance. There's usually or you're paying privately, there's usually cost associated with it. Sometimes people have to take off work. They have to do the mental work of showing up to therapy. So for someone to do all of these things, you would think there is a reason why they want to do it. And the person who's coming in superficial, I'd want to make sure that they're not motivated by someone else. Are they there because they actually want to change something, or are they there because of someone else pushing them into therapy? Sometimes I've seen that. Are they there because do they feel like that they're ready? And so being able to explain to them that some of the things that they are going to talk about is going to help them improve and see their situation a little bit differently. Sometimes people don't want to let go of the power of sharing information. Sometimes there's privacy concerns, fear of being judged, fear of being blamed. That's probably another way to be able to dig into this. So I have a lot of different things going through my mind when someone is superficial, especially beyond like the second or third session, when they keep showing up and yet they're not truly showing up. I really want to be able to understand that more. So some of the suggestions that I mentioned, just to recap, I think that it's important to be able to understand their motive for coming in therapy, being able to recognize and call out all the energy and the resources that it takes to actually show up. And so therefore, there's likely a reason why they're there. Being able to really understand if they are ready for change, being able to look at the strength, the trust that's built in the relationship or what they may feel like is happening. And then also taking a little bit of a look at that power differential. Hopefully that got a little deeper.
Thanks, Cynthia. So I think we have time for one more question, and let's go with, can you give some examples of the Therapeutic Alliance questions that you recommend therapists ask during sessions?
So, you know, the thing about Therapeutic Alliance questions is that what you ask is not as important as just the fact that you do ask them. There's the outcome rating scale, the session rating scale. So you can go online and actually find some of the original measures from Scott Miller. So you can definitely Google Therapeutic Alliance questions. But one of the questions that I think is really helpful is for, well, first of all, I do believe that you should use a rating scale. I don't think that you should ask an open-ended question in many cases, because there's too much room for the client to agree with you or to validate or to tell you what they think you want to hear. So being able to use a numerical score, oftentimes it's just 1 through 4 on how much somebody agrees or disagrees. At PATH, we send folks a survey ahead of time so that they can document it. One of the questions that we ask, it's a statement of how much a person agrees or disagrees. It's, I feel like my therapist understands me. That's a basic one. Another one that we ask is, I feel like we are working on the goals that I want to be working on. Sometimes questions get modified for younger children. I'm blanking on the wording of the kid questions. I like my therapist is a question that I have seen for young children. So just being able to have that connection with a therapist. Those are sort of the ones that that are coming to mind off the top of my head. So I know I didn't cover a ton of content, and yet it was packed with a lot of resources and materials. And yet I really appreciate all the different questions and, quite frankly, just the universality of all these different scenarios that we come from. I am by no means an expert on this, but I know that over the years, it's something that I've experienced quite a bit. And I really tried to do the topic justice by looking at some of the research that was out there, talking with some other therapists. And I really hope that this is something that gives you some takeaways for being able to think about how to navigate this when you're working with clients. We know that this happens. It's not always about you, but sometimes it is. And so it's a great topic to be able to pay attention to. So I just want to thank everybody for showing up. It's a sunny day for me here, and I hope that everyone has a great week.